Clinical Measurement SAQ 15, Capnography. Describe how a capnometer measures CO2 concentration, 5 marks. Infrared spectroscopy is the main method of CO2 measurement in the operation theatre. Both inspired and expired CO2 concentration can be measured continuously. Any molecule that contains two or more different atoms will absorb infrared radiation, such as CO2, nitrous oxide, and inhalational anesthetics. CO2 absorbs infrared radiation maximally at a wavelength of 4.3 micrometer. Applying Beer-Lambert law, energy absorbed by CO2 from the narrow band of infrared light passing through a gas chamber is proportional to the number of CO2 molecules in the gas sample times the distance traveled. The remaining unabsorbed infrared radiation falls on the photodetector, which is a thermopile detector, and heat is produced and measured by a temperature sensor. The heat generated is proportional to the partial pressure of CO2 present in the gas sample. This produces an electrical output which is measured. The concentration of CO2 can then be determined by comparing the absorbance with that of a known standard. Infrared light also passes through a reference chamber which contains room air periodically, and its amount is detected by the photodetector for calibration against zero with a known CO2 concentration to avoid drift. The amount of infrared absorption is compared between the sample and the reference chamber, and CO2 values are calculated. B. Outline the clinical information obtainable from a capnogram, 5 marks. A capnogram is a graphical plot of CO2 partial pressure versus time. Information regarding airway and breathing, circulation, and others can be obtained. ETT placement. If it is in the trachea, a normal waveform will be produced, indicated by capnograph waveforms that do not fade after multiple breaths. If ETT is placed in the bronchus, there might be biffid waveform due to delayed expiration from the other lung. ETT placement in the esophagus results in small vanishing sinusoidal waveform. In this connection, there will be no waveform. Ventilation. Mode of ventilation. In spontaneous breathing, there will be increased slope of phases 0 and 2 and shortened phase 3. In mechanical ventilation, there will be squarish waveform and longer phase 3. Adequacy of ventilation. Information regarding respiratory rate can be obtained, which may indicate hyper or hypoventilation. Alveolar dead space is proportional to the difference between EtCO2 and PaCO2, which is normally 2 to 5 mmHg. An increase in PaCO2 and EtCO2 gap may be caused by pulmonary embolism, hypovolemia, hemorrhage, and excessive PEEP. Increased PA-EtCO2 gap in early ARDS is a risk factor for death. In rebreathing, there will be increase in phase 1 and 3. This is important for Mapleson classification circuits. Baseline is not zero, and EtCO2 rises. Airway obstruction is indicated by increased slope of phase 3 and loss of alpha angle. This may be caused by bronchospasm. There is increased heterogeneity of time constants of alveoli. Earlier emptying of fast lung units with low pCO2 and later emptying of slow lung units with high pCO2. This is worse if there is short expiratory time. In emphysema, there may be reversal of slope of phase 3 and increased beta angle. Markedly increased alveolar volume results in early completion of gas exchange. Small airway closure is indicated by terminal upswing or pigtail. This is due to closure of lung units with low pCO2 and continued emptying of lung units with high pCO2. This is seen in pregnancy, obesity, and in poor compliance such as ARDS. Equipment dysfunction. Circuit obstructed externally results in reduced slope of phase 0 and 2. Circuit disconnected, there will be no waveform. Inspiratory valve stuck open, there will be reduced slope of phase 1. Inspiratory valve stuck closed, there will be no waveform. Expiratory valve stuck open, there will be increased phases of 1 and 3. Expiratory valve stuck closed, there will be reduced EtCO2. Sampling line leak may be indicated by dual plateau of phase 3. The increased pressure at onset of inspiration reduces air entrainment. Circulation. Low cardiac output results in reduced phase 3. In arrest without CPR, there will be no waveform. In cardiac arrest with CPR, EtCO2 of more than 20 mm mercury indicates effective CPR. Cardiac oscillations are small, regular, rapid sinusoidal waveforms seen in low-frequency ventilation. Cardiac impulses causes back and forth motion between exhaled and fresh gas. Other information. EtCO2 is a surrogate for PaCO2. Normal EtCO2 is 30 to 40 mmHg, and normal PA-EtCO2 gap is 2 to 5 mmHg. Changes in EtCO2 can guide the diagnosis of various clinical conditions. EtCO2 is increased in hypoventilation, rebreathing, sepsis, MH, hyperthermia, skeletal muscle activity increase, and hypermetabolism. Decrease in EtCO2 may be seen in hyperventilation, pulmonary embolism, hypoperfusion, cardiac arrest, hypometabolism, hypothermia, hypovolemia, hypotension, airway obstruction, breathing circuit leaks, circuit disconnections, ETT displacement, etc. Return of muscle power. Spontaneous inspiration produces curare cleft in phase 3. During the plateau phase, a large cleft occurs as the patient makes a transient respiratory effort to draw fresh gas over the infrared sensor. Soda-lime exhaustion may be indicated by increased phase 1 and 3 for a given minute ventilation, which normalizes with increased fresh gas flow. Increased metabolic rate results in increased EtCO2 and height of phase 3. Increased metabolic rate may be seen in sepsis or malignant hyperthermia. Reduced metabolic rate may be seen in hypothermia. Confirmation of proper placement of feeding tubes for enteral nutrition. If capnography trace is present, the feeding tube is misplaced in the trachea and this should be repositioned. Additional information. Phases of the capnograph. Phase 1 baseline should be near 0 mmHg. Phase 2 expiratory upstroke represents the transition from anatomical dead space to alveolar gas. Phase 3 is alveolar plateau and represents alveolar gas exhalation. Phase 4 terminal upswing is rarely present. EtCO2 approximates PaCO2. Phase 0 inspiratory downstroke represents early inspiration. Alpha angle at transition between phase 2 and 3. Beta angle at transition between phase 3 and 0. Sources of error. Confusion with other gases. Peak infrared absorption wavelengths of CO2 is 4.3 micrometer. For nitrous oxide is 4.5 micrometer. Carbon monoxide is 4.7 micrometer. Presence of nitrous oxide and carbon monoxide therefore causes falsely high PCO2. Water vapor absorbs infrared radiation widely and causes falsely high PCO2. Presence of bronchodilator propellant and halotane may cause confusion as well. Solution is to have a reference chamber and water trap. Collision broadening is widening of the absorption peak of a gas when in the presence of another gas due to collision between molecules raising their energy levels. 50% nitrous oxide widens CO2's absorption peak by 10%. Solution is by having a reference chamber. Ram gas effect. Pressure drop across the sampling line occurs. There is reduced total pressure inside the sampling chamber. This results in reduced PCO2. Solution is to have regular 3-point calibration. Dilution by fresh gas. Sampling of fresh gas may occur in expiration if high respiratory rate and low tidal volume, such as in ventilating neonates and young children. Dilution of the EtCO2 can occur whenever there are loose connections and system leaks. Sampling line disconnection. If complete, there will be no signal. If partial, there will be entrainment of room air. Blockage by water condensation. This may be avoided by having a water trap. Cardiogenic oscillation if apneic. During prolonged expiration or an expiratory pause, gas flow exiting the trachea approaches zero. Sampling line may aspirate gas from the trachea and inspiratory limb, causing ripples on the expiratory CO2 trace. Capnography underreads if plateau is not reached, such as in severe asthma or COPD. During pediatric anesthesia, it may be difficult to produce and interpret EtCO2 because of the high respiratory rates and small tidal volumes. Sidestream versus mainstream capnography. Disconnection is possible for both. Sampling catheter leak is more common in sidestream capnography. Calibration of gas is required for sidestream capnography. Sensor damage is more common in mainstream capnography. Multiple gas analysis is possible for sidestream capnography, but not for mainstream. Sidestream capnography may be used on non-intubated patients, but not for mainstream capnography. Pros of sidestream capnography versus mainstream capnography includes no increase in dead space, it's lighter, and remote monitoring is easier. Cons includes longer transit time, resulting in longer response time. Sidestream is prone to obstruction and prone to leaks.